Okay, you guys can see my screen, right?
Yes.
Okay, so this patient has Crohn's disease, and we were looking at their bowel. We usually don't give oral contrast. I don't know why we got it in this case, but especially not for our CT enterographies. But you can see the small bowel looks pretty normal. And then the colon looks pretty normal. There's a lot of fecal material, sigmoid colon and rectum. And they were having perirectal pain. So what do you guys think about this?
There's a perianal fistula and an abscess going down.
Yeah, exactly. So we see this abscess and we're concerned about and CT is not very good for looking for these fistula, but we can see maybe hallucinate a little fistula there. And it's going into the ischioanal fossa here. So we wanted to look at that fistula better. So we got an MRI. And actually I have a T2 with FATSAT as well, but now we can see this fistulous tract here extending from the anus. And I'll show you a couple more sequences. This is the T2 with FATSAT, which sometimes if this fistula is very small or subtle, can be even better. And so again, we can see that fistula. It's basically like a transsphincteric fistula going through both the internal and external sphincter and into the ischioanal fossa. You guys have any other thoughts? I'm going to show you the post-contrast.
Some kind of mucinous something.
Why do you say that?
It's just too bright, really doesn't look like just fluid.
Good. Hold on, I'm trying to find, okay. Okay, so here's our post-contrast. A lot of this area that it does seem to maybe have some contrast within it. And then you'll notice this part here actually has quite a bit of contrast enhancement. I'll go back to the T2 and just show you that part there. So that part that was enhancing was, so this was the part that we thought was like an abscess, but like Kedar was saying, it's very bright. It almost looks like it has some material within it. That part wasn't really enhancing, but you can see this part here actually has like all of this gray stuff within it. And this was all enhancing down here. We still thought it was a fistula with an abscess. So they put in some cetons. Because the patient has Crohn's disease. So we thought, okay, these are, you know, they like to have fistulizing disease. We put these cetons through the anus, through the fistula into that collection. And finally, they sent this off for cytology, and it was a mucinous tumor. And then this is what it kind of turned into afterwards. So we can still see that it comes from the wall. There are fistula, but now we can see that there is this large, definite soft tissue component, and that this guy does not really look like an abscess. It looks more like it has like structure to it, lobulated borders. It's actually going all the way up to the sacrum here. So this was a mucinous tumor. So this is a pitfall that several people have been showing at national conferences lately, and I think it's something we need to be more and more aware of. These mucinous tumors can mimic abscesses. They are, especially in patients with Crohn's, you might be prone to thinking that it's an abscess, but Crohn's patients are also at higher risk of developing colon cancer. So just be really careful if you see, for example, if you saw this on that initial CT, you can suggest that this is an abscess, but always recommend an MRI. And then on the MRI, just be careful of those additional signs. Like if you start seeing those lobulated borders, the very T2 brightness, the T2, this kind of soft tissue in it and enhancement, just have a really high level of alert that this could be a mucinous tumor. Any other teaching points? Okay, I'm going to try to switch to the next case. Hold on one second.
Is there a diffusion, Aarti?
Yeah, hold on, let me see.
Because if it were an abscess, it should have restricted, but a mucinous tumor typically will not restrict.
Okay, so this was on that last MRI I showed you towards the end. Sorry, I'm just trying to window it. You can see a lot of, this is the diffusion. And actually that soft tissue part is dark on the DWI, and then this is the ADC. So actually most of it is shining through.
Right, so that would make abscess unlikely then.
Yeah, that's a really good point. But the soft tissue part actually, what is it? It's dark on the ADC, but it's also a little mildly bright on the DWI. So maybe that, hold on, let's go to a higher B value. Yeah, maybe that soft tissue part is restricting, and then the other part, the main fluid component part, is not restricting. It's just shining through. And that's a great clue for mucinous. Good. And also they did have a PET. I don't have it here, but the mucinous part was not like this, all this T2 bright part was not FDG avid, but this more soft tissue component was FDG avid. Okay. And then my next case is this one. This patient was having urethral, like difficulty voiding. What do you guys think?
See a urethral diverticulum, but then there's a cystic component more superiorly that seems to communicate with it.
Yeah, exactly. So this is a nice urethral diverticulum. You can see it wrapping around the urethra here. And then this is an extension of it actually superiorly. And so it actually ruptured and created this periurethral collection, which I haven't seen a urethral diverticulum do before. But basically urethral diverticulum is obstruction of these urethral glands, usually wraps around the urethra. It can cause obstruction, it can cause infection and stasis, you can get stones, you can even get malignancy in a urethral diverticulum. They usually marsupialize it going through the vagina. And in this case, so much of that material built up and then it ruptured into this collection here. I'll show you the post-contrast. Oh, actually, we don't have a post-contrast. This is just the fat set. You can see that there's also a lot of anasarca here, but. Okay, I'm going to stop sharing. I have some other cases on a different system, but if anybody else has cases.
I have one case, but I'm on a phone call.
Okay. We'll wait for you. Gitanjali, anyone else?
Yeah, Aarti, I had pulled one case. It was more like a consult case, like a companion to what you had showed last time, that HCC treated, and then question on how to use those LRTR categories. But I don't see Victoria joining in. It was more for, but that's okay. I can go ahead. Should I go ahead and present that?
Yes, definitely.
So this is her first MR. She's a young 40-year-old female who presented with multiple liver masses. And these were adenomas. Some of them had bled, so you can see those hematomas from the ruptured adenomas. And then this big lesion was biopsied, and this turned out to be a well-differentiated HCC. So IR went ahead and did embolization. I'm going to show you multiple images after her treatment. So these are our most recent scans, and we see that there is this lesion that there's a lot of internal necrosis, but there's still this peripheral area of enhancement. And on all these post-op scans, and we kept calling this as there's persistent enhancement in the lesion, and there's we kept on calling it as viable disease. So she had 3 TARE sessions, and after that she maxed out her radiation dose, and she can't have any more radiation to this lesion. So the question for IR was like, you're calling this as viable, but is there actually really viable tumor in this, or it's just some fibrosis left in the lesion, or some residual normal liver parenchyma that's infiltrating or extending into the margin of the lesion, that we are calling it as viable disease because it looked heterogeneously enhancing. So this was her scan right after her first or second TARE, I guess, and we called it as viable disease. And then another follow-up, called it as viable disease. Another follow-up. So I just want to show where I have done measurements at the same level. So what we're seeing, it's been progressively decreasing in size over time. And that nodular area of enhancement is really not showing any temporal evolution or any change. But at the same time, there is no increase or worsening. There are no worrisome features. So at what point should we start calling this as, now this is non-viable disease? The thing is, if we call it as non-viable, then she can be included on the transplant list and can get some definitive treatment. But otherwise, if the IR was like, eventually they started calling it as like no residual HCC from their side, and started kind of ignoring our report. So that's where I felt that we need to see where or how can we make this description of LRTR even better and be more specific, like even decrease in size and decrease in the temporal decrease in the enhancement should also be considered as LRTR or favorable treatment response in those LRTR categories.
Yeah, we should show this to Michelle because this is kind of exactly what she was talking about. But I think that how long has it been basically getting smaller?
It's been 2 years.
Yeah, I think you can start calling it. So she was saying that LIRADS might have an upcoming update about that, about these post-radiation cases, but that they're starting to call them evolving changes rather than equivocal. And then after 12 months of stability where it's not increasing and you basically just have this peripheral kind of fibrotic enhancement, which is basically like kind of dead fibrotic tissue from the radiation, starting to call it non-viable. So I would say that you can probably say, given stability, this is likely expected post-radiation change in non-viable tumor.
Yeah, so I think we should not just rely on presence of enhancing tissue within the tumor. We need to consider these other factors. And I think it's good to know that timeline. I think they're coming up with 12 months. So I think that's a reasonable timeline for. I think
that's a pretty big lesion, though. Are they thinking about doing a transplant?
Still not. I think I just read the note on her, and they are saying that the risk of getting a transplant is higher in her case. So they're still waiting, and she did not get any exception points for this one.
Okay, thanks. Nelly, are you ready? Okay, I can try to show one more while we're waiting for Nelly. This is very confusing. I've now logged into a different computer system. Okay, done. Okay, so this patient Tell me what you think about their biliary tree. And they are 50 years old. At this area here. Any thoughts? Okay, well, we were thinking that this was the saccular dilation of the left bile duct just before it joins the hilum. And we're thinking like these were all the right-sided ducts with a couple of anomalies because we have like two kind of large right anterior ducts here. But thought that this was basically in the spectrum of a type 4 choledochal cyst with just an intrahepatic component to it. And so the patient ended up getting, and then so for these choledochal cysts, they're thought to have like a increased risk of malignancy in the long term, maybe getting cholangiocarcinoma. So for this type of left-sided bile duct dilation, you would do a left hepatectomy. So you are losing quite a bit of liver for this lesion. But anyway, they were convinced enough that this was a choledochal cyst. This is a young enough patient. They ended up doing a left hepatectomy. And the path came back that there was this saccularly dilated bile duct. There was no dysplasia or malignancy within it, and it was compatible with the clinical diagnosis of a choledochal cyst. So I guess two of the teaching points are that one, there's no actual pathologic diagnosis that makes something a choledochal cyst. It's lined by the same kind of biliary epithelium that the bile ducts are lined by. Only if you see dysplasia can you kind of be more certain that it was probably in the risk factor category of a choledochal cyst. And yeah, basically in the path reports, they'll just say compatible with either the radiologic or the clinical diagnosis of a choledochal cyst. So you can't really be wrong. And then the other thing is basically, yeah, they do a risk reducing surgery. So if it's involving, one of the bile ducts or the other, they can do a hepatectomy. If it's a type 1 choledochal cyst, they usually try to resect as much of the common bile duct as they can and do like a risk reduction. And if it's like a diverticulum, they can just resect that separately.
Seems like a very radical surgery for a small lesion.
Yeah, I know. And I mean, this is a controversial thing that we've debated a lot about in our tumor boards. And that basically it's what do we do about these lesions? Say this was a 40-year-old, say it's a 50-year-old. Well, you're going to have to surveil this for the next 30, 40 years. I think there's also really variable literature about the real risk factor of a choledochal cyst. The ones that are in children are definite, when you have this huge saccular dilation of a type 1 choledochal cyst, those are in a child or a baby. That seems a lot more convincing to me. But in these adults, it's very controversial, like whether or not this would eventually lead to a cholangiocarcinoma and what the real risk is. So I don't know. I'm curious what you guys' thoughts are. I tend to, especially if they're older, like 80, 90 years old, I tend to kind of undercall them and downplay them, especially if their bile duct is just getting larger. This one seemed pretty convincing and is kind of, just like, what do we do about it? So
I mean, potentially you could follow this one up, right? I mean, it's not that large.
Yeah.
You do a non-contrast MR or even a contrast enhanced MR every 2 years, potentially.
Mm-hmm. Yeah.
It seems like a left hepatectomy just seems like a very major surgery.
Yeah. And one thing is they have to make sure they have enough volume. Luckily, this one was the left side. So left lobes tend to be smaller. So we definitely have enough, like more than 30% left on the right side here. But if they had to do a right hepatectomy, this might, this left lobe might be borderline, because you can see down here it's getting a little bit like smaller. Okay. Nelly, are you available?
Yeah.
Okay.
Okay, so this patient came in with pain. We've got a non-contrast CT. Here's the coronal. Okay, arrow signs. Just let me pause this so I can get rid of the markers. All right. Any thoughts? Is anybody talking? No?
Like some kind of
I had to answer a message briefly, but I do see, I see a tubular structure going into the inguinal canal and perforation, I think, with like extraluminal gas. I don't know, but yeah, there's extraluminal gas. I think there was pneumatosis. I'm trying to track that tubular structure back. Like, where's the cecum? Where's the appendix?
So here's the tubular structure.
Go back up.
The cecum is, oh, hold on, let me go back. Sorry, I gave you the pelvis. Let me give you this. Okay, so here's the ileocecal valve. There's the fat. So the cecum is north, and the appendix is probably here, with an appendiculus.
Oh, cute.
And then down south, far south, is the tubular structure with air in it.
So it looks like there's also gas in the left seminal vesicle, and then that may be the right spermatic cord.
Here's the, yep. So here's the air in the left seminal vesicle, and there's this thing in the right.
Looks like fluid and gas in that. So we're talking about like a necrotizing infection of the seminal vesicles that's extending into the right inguinal canal.
Let me window this. Oh my.
I like
Yes,
Teresa's
so,
diagnosis.
So what do you think? So yeah, so there's the seminal vesicle and there's an abscess in there. I windowed it earlier, and let me see if I can do it again. There's the prostate is abnormal right there. And then that extends the base, and then that extends into the seminal vesicles. And so, I'm sorry, what did you say was, what is this?
A spermatic cord.
Yes, yeah, right. So this is the vas, and then so there's a infection tracking up here into the inguinal canal, into the spermatic cord, and then it goes down, down, and then it goes into the testicles. So what do you see around the testicles?
There's gas along the testicles as well. So they're going to need to start taking things out.
Yes, that's right.
Immediately.
That's right. So they drained the seminal vesicle abscess. They and then they kind of explored this, and then you see the testicle was what we saw earlier, right? A little bit punctate foci, and now it's this.
So it's an abscess as well.
Where?
In the testicle and surrounding the testicle.
Yep, intratesticular abscess. And so they,
wow.
Yeah. Then they took the patient to the OR, and that's what it was. It was an intratesticular
I mean, is this
abscess.
treated as a Fournier's gangrene, or you think it is it?
Nah, it's not Fournier's, because Fournier's is not like perineal.
More the fascia, yeah.
Yeah, this is my thought process is a prostate abscess, or and like raging infection that extended into the seminal vesicle and then developed an abscess, and then that then tracked up the vas and then down the spermatic cord, and then infected the testicle, and then with the intratesticular abscess. That was
how old is this guy?
Okay, let me pause share. Figure out how old this patient is. Older, in his 80s.
That's crazy, Nelly. I've never seen a spermatic cord with air in it.
Isn't that amazing?
Yeah.
Yeah, so that's my case. So don't be fooled, right? Because
Yeah,
I mean,
it's amazing.
when you look at the original CT, and what is another differential diagnosis that we can that can be fooled with? I mean, you're confused with.
Well, I thought it was Fournier's gangrene initially, when you showed.
I was
And the
also wondering
somatic
if there was
cord.
like a trapped inguinal hernia
Yeah.
Yeah, like a
with appendix
strangulated.
going, strangulated small bowel or appendix down there.
Yeah, exactly. So it can very easily be confused for that. And so, you know, I think tracking that cord like Aarti was asking earlier and sort of, so it's a I think hard diagnosis to make prospectively. But now you've seen one, so.
Very cool. I have one more. I'm going to try to share an ultrasound. Ooh, okay. This is a young patient with pelvic pain. What do you guys think? "7 centimeter cystic mass. It's got all these dots in it."
Was there something echogenic along the wall at one of the images?
Yeah, there is
This is
this.
a dermoid, young, so.
Exactly. So I was thinking, I was like, yeah, maybe this is dot dash. It's not exactly dot dash because dot dash like should be longer and it's from the hair. But then recently I showed you guys that one with the Rokitansky plug, and the Rokitansky plug is like a soft tissue component in a dermoid, and it can look solid and it can have color flow within it. So I was like, oh yeah, this is probably a dermoid with like sebaceous material and a Rokitansky plug. It did not turn out to be a dermoid. You can see that it's pretty bright and cystic looking. As far as...
Do you have the T1?
Yes.
Yeah, T1.
This is the T1, so it's not super bright like an endometrioma would be. And I'll give you a in and out of phase to look for fat, because that could help clinch a dermoid.
Do you have the FATSAT images?
Yep, I'll show you in a sec. So we did not think that there was really fat in it. So dermoids can have both bulk fat. We don't see any etching, and it can also have intravoxel fat or microscopic fat from the sebum. We didn't really see that either. This is our T2 and our FATSAT. So not really, it's not satting out. So kind of just looked like a big cyst, but definitely looked more complex.
Like a cystadenoma.
Do you have diffusion?
Okay, two things. One is that thing that we saw on ultrasound does pan out over here. So there is that little nodule.
Does it enhance?
Here is the post contrast. It seems to enhance. So, and then you were asking
it's
about
like an ORADS higher up in the ORADS, right?
Yeah. So what would you give this as an MRI ORADS, Nelly?
God, I have to look it up. I think the 4 or 5.
So, okay. And then this is the diffusion. And so maybe, I don't know what's going on with that little nodule, maybe there, and the rest of it's not restricting. But the cool part about this case, and so Nelly, you said cystadenoma, which is a good thought. I was thinking,
or like a cystadenocarcinoma,
borderline tumor.
Yeah. So all of those things. So is it a cystadenoma? Is it a cystadenocarcinoma because it has this little nodule on it? So because it had that nodule, we couldn't say it was just a benign dermoid. They ended up removing it, and this turned out to be a cystadenofibroma, Serous cystadenofibroma. So just a couple of points about serous cystadenofibroma. I mean, I think this is kind of a retrospective diagnosis, but I mean, so one cool thing about it is that it does look like a serous cystadenoma in that it was very loculated, like a big cystic lesion. And this part is the fibroma part. And this is the cool thing about the MRI ORADs, I think, is that there is this category of, they call it like dark. So if it's dark on T2 and it's also dark on DWI and ADC, these are usually fibrous tumors. And so they can be like a fibroma or a fibrothecoma. And those are actually in the MRI ORADs, I believe they're ORADs 3, where they basically don't say that you should resect these lesions because fibromas, fibrothecomas have a very low rate of malignancy. And Brenner tumors, which are the other solid epithelial neoplasms, also have a very low rate of malignancy. And so they basically put it in a lower MRI ORADs category if it has a fibrotic component to it. So in retrospect, I guess we could have put together that this looked kind of like a serous cystadenoma, and then this part looks very dark. So this is like a fibrous part. So in the end, like, you know, this was a serous cystadenofibroma. These are benign lesions and they can mimic malignancy, but you should be comforted if the solid part that you see looks fibrotic.
I have a case, a companion case.
Cool. Okay.
Share my screen. Okay. So patient had pelvic pain. So there's our T2. T1 is here. Okay. In a post phase, okay, actually I have the arterial, so let me just give you the subtraction. Where's my in a post phase? Oh, here. I'm pausing. Okay, here's the here. Here's the post phase.
Nelly, I'm seeing a static sagittal image.
You are seeing a stat. Oh, shoot. Is that, can you see an post phase imaging now?
Yes, yes.
Okay, so here is your. Where's the in phase? Okay, well, while I look for, here's the. Diffusion. Okay, any thoughts or anything? Let me see if I can.
Can you go back to that T2?
Yeah. And then here's the non-faceted images. See if I can. So that's that. And then here's non-faceted. So if I can scroll them at the same time. So
So
sorry,
there's like layering fat like on the top of the fluid parts.
Yes, that's what I'm trying to show you.
Which I would think about a dermoid then.
Yeah, so that's sort of what we came up with. And initially it's a confusing case to me because there's all these different T2 signal intensities. Some, there's ranging, like, we call this T2 shading. I mean, that would fit the bill. There wasn't any, there's no internal enhancement in any of these cystic loculated components. But then when you look at that area, it sets out on the fat sequences. So this is fat. I don't know if endometriomas can coexist with dermoid cysts, but the fat, at least within the dermoid cyst, sort of, suggests more of a dermoid over like an endometrioma. I don't know what else. I mean, it's like I don't have the path yet. Any other thoughts about this case in the DDX?
I don't know any ovarian neoplasms that have fat in them, but it would be great to get the path because otherwise it looks weird for a dermoid.
It looks very weird, right? It like
Yeah.
threw me off initially, and then we saw that fat suppression on FATSAT images. So we're like, well, what else could it be? You know. So I'll follow up and let you guys know.
Cool. Anyone else? Okay, we will end early. I will see you guys later.
Thank you, Aarti.
Thanks all.
Thank you, Aarti.
Thank you.